All right. Well, hello, everybody. Thanks for joining. My name is Charlie Leonard, and it's my pleasure today to give the third and final session in our webinar entitled Studying the Health Effects of Drug-Drug Interactions. Today I'll be speaking about one particular study we conducted to look at the clinical importance of a drug-drug interaction, in particular a class of anti-diabetes drugs known as sulfonylureas, combined with lipid-lowering drugs and the risk of serious hypoglycemia. My talk should be about 45 minutes, and then I'd like to spend the last 15 minutes or so addressing any questions you might have that I just asked you to type into the chat box at that time. So again, as I mentioned, I'll be talking today about the combined effect of sulfonylurea drugs and lipid-lowering agents, for example, statins and fibrates, on the risk of serious hypoglycemia. By way of disclosures, the work that I'll be discussing today is supported by the National Institute on Aging and the National Institute of Diabetes, Digestive, and Kidney Diseases, and I personally have no conflicts of interest to report. So here's the talk roadmap for today. I'll first tell you that sulfonylurea drugs, a class of drugs used to treat type 2 diabetes, are still relevant in the treatment of that condition. I'll then tell you that sulfonylureas have differential risks of serious hypoglycemia. And then I'll end by talking about the fact that hypoglycemic effects of sulfonylurea drugs may be potentiated by fibrate drugs. Now, you might be thinking, wait, didn't I register for a DDI talk? So why the first two talking points? That is, why do I need to hear that sulfonylureas are relevant and sulfonylureas have differential risks of serious hypoglycemia? But I'd argue that justifying the clinical importance is worth just as much effort as describing the drug-drug interaction. So I'll proceed through those two areas first, and then spend a fair bit of time diving into the detail of the study we conducted looking at that drug-drug interaction. So first, sulfonylureas are relevant therapies. Probably not surprising to the individuals on the call, but diabetes is an incredible public health problem. It's of epidemic proportions. It currently afflicts about 30 million Americans. The prevalence throughout the nation is currently 10%, and it's anticipated to rise to about 30% by the year 2050. Currently, prevalence estimates vary quite widely depending on state. In my state here of Pennsylvania, at least the 2014 estimate is upwards of 10 to 15% currently. The costs are pretty extraordinary at $245 billion. The disease disproportionately affects minorities, and diabetes is either the primary or contributory cause of death in about 300,000 patients for a given year. Here are the 2017 standards of care of the treatment of type 2 diabetes as published by the American Diabetes Association. Once an individual makes dietary or lifestyle management changes and pharmacotherapy is deemed the next appropriate step, most patients are started with monotherapy with metformin, a high-efficacy drug that has, in general, a very low risk of hypoglycemia or low blood sugar. Metformin alone is typically not enough to treat most patients, so patients typically progress on, especially as their disease severity increases over time, to a dual therapy regimen, which is a drug in a class that is added to metformin. And you can see here that per the standard of care guidelines, there's a recommendation to add either a sulfonylurea drug, a thiazolidinedione, a DPP-4, SGLT2, GLP-1, or in some cases insulin. And really the ADA makes no recommendation as to which is the first or second line dual therapy add-on to metformin. So really this has been of late a personalized decision that's made between the provider and the patient, and things might change once the great trial findings come out in the next year or so. That said, there have been cost-effectiveness models to suggest that some of the newer agents, like DPP-4 inhibitors and SGLT2s, may have decreased value. And sulfonylureas, while an older drug class, and inherent in the fact that it's an older drug class, the prescribers have extensive experience with these drugs. And because they're available generically, they're typically a very low cost. And further, in the 90s, the well-known UK PDS study supported the fact that sulfonylurea drugs decrease microvascular risk. How were oral antidiabetics used, both nationally and then in a disadvantaged population? If you look at the panel on the left, these are national estimates. On the y-axis here, the number of prescriptions in millions, and you can see the years ranging from 2003 to 2012. And most notably, you'll see use of prescription drugs going up over time. That's indicative of a couple factors, but not the least of which the fact that diabetes is becoming more prevalent over time. But the thing that's important to note is the section of each of these bars that is contributed by sulfonylurea drugs hasn't shrunk over time, even as newer agents come to the market. So these drugs are still relevant and used by prescribers. If you look at the right-hand panel and a sample of Medicaid patients that we have access to here at the University of Pennsylvania, you can see that use of these three main sulfonylureas is generally going up over time. One notable example, or a drug contrary to that point, is glyburide, principally because in older adults, the glyburide is a potentially inappropriate medication that was named by the American Geriatric Society as a drug to avoid in elders. So that potentially describes the fact that glyburide use has slightly been going down over time. So in short, sulfonylurea drugs, despite the fact that they're old and no longer novel, aren't going away. For those more interested in this ongoing debate as to whether or not providers that treat folks with type 2 diabetes should still be using these older sulfonylurea drugs, in 2015 in Diabetes Care, there was a really nice point-counterpoint set of articles that really went after the arguments as to whether or not these drugs still serve us well or are older therapies that kind of should be abandoned. So there are some important major knowledge gaps in the safety of sulfonylurea drugs, first of which is hypoglycemia. So a fair bit is known about sulfonylureas and how they cause hypoglycemia. It's known that they cause hypoglycemia probably less than insulin and probably more than everything else. But there's still a lot to be known about treatment effect heterogeneity. Further, there's major knowledge gaps in terms of drug-drug interactions with sulfonylureas, and in particular, exaggerated pharmacologic effects of these drugs, which are meant to lower blood glucose, but in exaggerated fashion can cause hypoglycemic events. There are also major knowledge gaps in cardiovascular effects and cerebrovascular effects, some of which we work on here in our group, but I won't be discussing those today. So now that you're reminded, hopefully, that sulfonylureas are relevant therapy, I'm now going to talk about the fact that different sulfonylurea drugs have different risks of serious hypoglycemia. Hypoglycemia is a very important outcome. It's an expected effect of these drugs. It commonly occurs. In fact, in the first 6 months of being put on a sulfonylurea, about 20% of patients will experience a hypoglycemic event. Hypoglycemia is a major barrier to glycemic control. It's something that's frequently feared by patients and caregivers. And it's not simply just that the blood glucose goes too low. There are significant sequelae of these types of events leading to falls, dementia, seizures, coma, death, major adverse cardiovascular events. So not surprisingly, the U.S. Department of Health and Human Services in their National Action Plan for ADE Prevention named anti-diabetic drug-induced hypoglycemia as one of their 3 high-priority targets, in addition to warfarin and bleeding and opioid overdose. And they made calls within this report to identify the rates of serious hypoglycemia in the ambulatory care setting. So that led us to conduct a study to look at what the rates were of, that is, the rates of hypoglycemia in monotherapy users of different drug classes for type 2 diabetes. And we hypothesized that the rate of serious hypoglycemia in monotherapy users would be greatest for sulfonylureas, followed by meglitinides, then TZDs, then metformin. Now, there have been few studies looking at differential effects within the different sulfonylurea drugs, so we wanted to focus on that. And then outside of the context of randomized controlled trials, there really haven't been careful examinations of serious hypoglycemia risk in TZD users and meglitidine users. And while you could cobble together different parts of different studies to try to get at some of this information, cross-study comparisons are really hindered by differences in the study populations and outcomes that are inconsistently defined. So our objective was to examine the rate of serious hypoglycemia among monotherapy users of metformin, sulfonylurea, meglitidine, and TZD regimens. Now, you may have noticed that just a few slides ago I said that the 2017 standards of care for the treatment of type 2 diabetes suggest that everybody should start on metformin monotherapy. So why would we be expected to see sulfonylurea monotherapy users or TZD monotherapy users? There are a number of reasons for this. One, the guidelines haven't always as highly emphasized metformin, and we use data that went back a number of years where treatment paradigms were slightly different. And then there are a substantial number, more than you would think, number of patients that are intolerant to metformin. They can't tolerate the GI side effects, so providers are forced to use monotherapy with other agents. There are also some contraindications to metformin. So individuals that have severe kidney disease might be started with monotherapy with one of these other agents. So to elucidate the rates of serious hypoglycemia, we conducted a propensity score adjusted cohort study. In a data set here that we have available to us at the University of Pennsylvania, it's a Medicaid data set from 5 states, California, Florida, New York, Ohio, and Pennsylvania. Currently, we have claims from 1999 through 2012. When we conducted this study at the time, we had data from 99 through 2010. And notably, the 5 states that we have data for are 5 of the largest Medicaid states in the U.S. and actually represent 40% of national enrollment. Our participants in this cohort study were adult new users of antidiabetics as monotherapy. Our exposure of interest were prescription dispensings for the antidiabetics that I presented before. We use metformin as our referent exposure because metformin is thought to either have no or a very low risk of hypoglycemia. For our outcome of interest in this cohort study, we used a validated ICD-9 diagnosis-based algorithm to identify serious hypoglycemia, and how we defined that was presentation to the emergency department or a hospitalization. And we followed people from when they started their monotherapy up through 180 days to identify these serious hypoglycemia events. In prior work done by Adit Gindi at Colorado and colleagues here at the University of Pennsylvania, this outcome has been demonstrated to have a very high positive predictive value. To address confounders in this study, we used a multinomial propensity score approach. And by way of analysis, we looked at crude incidence rates that were directly standardized to 2010 diabetes population. And for our modeled results that adjusted for confounding, we used Cox proportional hazards regression. So here are our findings. We identified over 900,000 users of monotherapy of one of these drugs. And within 180 days of following those individuals, we identified about 6,400 serious hypoglycemias. That is, individuals that presented to the ED or were hospitalized for hypoglycemia. This table below presents standardized occurrence rates of serious hypoglycemia. And why I'm saying occurrence rates here and not incidence rates is because hypoglycemia is a condition that can recur. We allowed for the counting of multiple events per individual. So rather than say incidence rates, which suggests that we counted only the initial event per individual, these are occurrence rates. And what you can see here that is above the red line are the sulfonylurea drugs have the highest overall occurrence rates of serious hypoglycemia, followed by the meglitinides, then followed by the TZDs and metformin. Now these are all crude rates that aren't yet adjusted for confounding, but you can see in general how things fall out here. And you'll also note that when we looked at average daily dose of these drugs and stratified it by high versus low dose, you can see that high dose was always more likely to cause hypoglycemia than low dose. Here are our propensity score adjusted hazard ratios. That is, these are the confounder adjusted results. You can see here at the bottom that metformin was our a priori reference exposure. So you can see the hazard ratio is set at 1 with no confidence intervals because everything is compared to metformin. And you can see that above the red line are our 3 sulfonylureas. So you can see both, that is glimepiride, glipizide, and glyburide all have statistically significantly elevated hazards of serious hypoglycemia compared to metformin in the range of 2.5-fold to 4-fold. You can see some differences in meglitidine, nataglinide suggests maybe a 20% increased risk that wasn't statistically significant. Repaglinide about a 2-fold increase over metformin. And then you can see the TZDs, one of which is consistent with metformin at no increased risk, and pioglitazone, which appears slightly safer than metformin in terms of hypoglycemia. So the bottom line is among oral anti-diabetic monotherapy users, sulfonylurea users, depending on agent, have a 2.5 to 4-fold increased risk of serious hypoglycemia versus metformin, and glyburide is the worst offender. Meglitidine users about 1.5 to 2 times increased risk versus metformin, and in general, the rate of serious hypoglycemia in TZD users was similar to metformin. But as you know, these agents aren't prescribed in a vacuum. So we need to start thinking about how concomitant drugs might affect the risk of serious hypoglycemia in users of these sulfonylurea drugs. So I'm going to talk about the fact that hypoglycemic effects of sulfonylurea agents may be potentiated by fibrate drugs. So for those of you that happened to be on the session that was last week, I introduced this case of a 53-year-old woman with diabetes who had been taking glyburide, a sulfonylurea, for 9 months. She was on 5 milligrams a day. At some point later in her therapy, gemfibrozil was added to treat her hypertriglyceridemia. And when she came in the clinic about 3 weeks later, she and her husband had stated that she'd been having hypoglycemic attacks at home and had even fallen on 2 occasions. So the provider reduced the dose of glyburide from 5 milligrams a day to 1.25 milligrams a day. This was a case report published in 1991 by Ahmad. And when Ahmad ended the case report, he stated that when gemfibrozil is given to a patient receiving a sulfonylurea, the patient should be closely watched for loss of glucose control. Just want to point out that this was in 1991. So how typical might this be? Well, it's really a very commonly occurring thing because dyslipidemia often occurs in folks with type 2 diabetes. In fact, it's a major risk factor for mortality in diabetes. An individual with diabetes tend to have this characteristic phenotype, whereas they have low HDL, they have high small dense LDL, and they have high triglycerides. So you can imagine an individual with type 2 diabetes commonly being put on a statin and or a fibrate. That being said, there should be some concern that antihyperlipidemics could inhibit the hepatic metabolism of sulfonylurea drugs, leading to an increased concentration of the sulfonylurea. So here's just a very simplistic overview of the metabolism of sulfonylurea drugs. You can see here that the different agents, glyburide, glipizide, and glimepiride, are all slightly metabolized differently, primarily via either CYP3A or CYP2C9. Almost always the inactive metabolites, sometimes weakly active or active metabolites. But essentially this process needs to occur in the liver to break the drug down from active form to an inactive form. But as you might imagine, some statin drugs that are concomitantly prescribed and fibrates that are concomitantly prescribed can inhibit these metabolic pathways and lead to increased concentrations of these sulfonylureas, which amplifies their glucose lowering effects and can cause serious hypoglycemia events. Now, as I talked about last week, in DDI nomenclature, the drugs that have an effect or cause an action are known as precipitant drugs, and the drugs that are affected are known as object drugs. So I may refer in the rest of the presentation to either sulfonylureas and statins and fibrates, or occasionally object drugs and precipitant drugs. So aside from the fact that a DDI or drug-drug interaction might be theoretically possible, it's also important to keep in mind, to contextualize things, that these statin and fibrate drugs in and of themselves may affect glucose homeostasis. So this is a debated area, but there's some evidence to suggest that maybe rosuvastatin alone can increase blood glucose, where pravastatin maybe has no effect, maybe can slightly decrease blood glucose. But some people suggesting that atorvastatin, lovastatin, and simvastatin have no impact on blood glucose. Similarly is this area of debate with the fibrates, in that in rodent models and small uncontrolled trials of humans, fibrates in and of themselves have been shown to reduce glucose. But in this one particular trial, the field trial, in folks with diabetes, fibrates didn't have an impact on blood glucose. So this is really an area of debate, but it's important to keep these things in mind when you're evaluating the potential drug-drug interaction between a sulfonylurea drug and the addition of a statin or a fibrate. So because we wanted to investigate this, we conducted a cohort study, and our hypothesis was that the risk of serious hypoglycemia in concomitant users, that is, of a sulfonylurea plus a statin or fibrate, will increase with the strength of that antihyperlipidemic's ability to inhibit either CYP2C9 and to some extent CYP3A4. Because if those enzymes are inhibited, you get an increased concentration rather of the sulfonylurea. So you might be thinking to yourself, these drugs have been around a long time, hasn't this been elucidated already? And the answer is truly no. So I went just to one drug-drug interaction module, and I'm not picking on any particular company, by design here, because they all essentially bring back the same information. But if you type in gemfibrozil and glyburide and you have a look for a drug-drug interaction, you see a severity of moderate. It says that this combination of a fibrate and glyburide may result in hypoglycemia. Consider dose reduction. And if you look at the evidence supporting the fact that these drugs interact, it points to that single case report that I talked about a few slides ago by Ahmad in 1991. And we all know that case reports, while important for hypothesis generation, really provide a very low level of causal evidence. So our goal was to generate causal evidence to either support or refute this potential drug-drug interaction. So our study objective was to elucidate the effect of the putative drug interaction between sulfonylureas and antihyperlipidemics on our outcome of serious hypoglycemia. We also wanted to look at the time course of the drug-drug interaction. So when the two drugs are given together, does the interaction occur soon after that or at some point later? Our design was the use of propensity score adjustment in a cohort study. We used our same Medicaid database of 5 states, that is California, Florida, New York, Ohio, and Pennsylvania. For this study that we published a few years ago, at the time we had data from 1999 through 2009, and we included adult new users of concomitant therapy. So every individual we included in the study was exposed to one of the 3 sulfonylurea drugs, and then we looked at differential exposure to antihyperlipidemics. And our exposure of interest, therefore, was what antihyperlipidemic was added to the regimen. We used pravastatin as our referent exposure because it's been shown to have negligible CYP inhibition, so wouldn't be expected to have this pharmacokinetic interaction that I showed a few slides ago. And plus, there's at least some data to suggest that pravastatin has minimal to no effect on fasting and day-long plasma glucose in and of itself. We used the same validated IC9-based algorithm for serious hypoglycemia, and we followed individuals forward from cohort entry, that is when they started concomitant therapy, for a maximum of 180 days. We addressed confounding, again, by adjusting for multinomial propensity scores, and this time we used an empiric approach developed by Harvard University called high-dimensional propensity score adjustment. By way of analysis, we used Cox proportional hazards regression. And I just want to give you a visual of how individuals could enter this cohort study. Again, as I pointed out, cohort entry began when individuals became concomitantly exposed to both drugs, and this could occur in three different ways. This way is one example in which individuals started both of the drugs on exactly the same day. As I pointed out, from that point forward, unless they had a censoring event, we followed them up through 180 days, and then we required a year baseline period during which we measured baseline covariates and adjusted for those in our outcome models, in our regression models. This scenario here, because the individual happened to start both of these drugs on the same exact day, in DDI nomenclature is considered combination triggered cohort entry. That is, both drugs appeared on the same day, and that triggered their entry into the cohort. You could also imagine a scenario where someone was previously on a sulfonylurea and at some point later had an anti-hyperlipidemic added, whether it be a statin or fibrate. And the addition of that anti-hyperlipidemic at that time triggered cohort entry. So this is known as either precipitant triggered or, in this specific case, anti-hyperlipidemic triggered cohort entry. And then finally, the third scenario where someone was already on their statin or fibrate drug and they were initiated on a sulfonylurea, at that point becoming concomitantly exposed, and then we followed them 180 days forward from there. And in this case, it would be object drug, because the sulfonylurea is the object drug, or sulfonylurea triggered cohort entry. So we allowed individuals into this cohort study regardless of what mechanism by which they became concomitantly exposed. Now, for those who weren't on the call last week, I talked more about some of these methodologic issues in studying drug-drug interactions, and just for those folks not on the call, pointing out that Sean Hennessy and I had a paper published in CPT last year where we went through some of these issues of the initiation order of the object and precipitant. We also talked about issues of outcome validity, negative control pairs, importance of DDI time course, and screening methods for those so inclined to go. So here are the results from our drug-drug interaction study, again elucidating whether or not the addition of a statin or fibrate to sulfonylurea therapy increases the risk of serious hypoglycemia. Now, we had separate cohorts for users of glyburide, glipizide, and glimepiride. We did that because these agents use slightly different pathways in the liver for their metabolism. You can see that depending on agent, we had somewhere between 100,000 and 240,000 concomitant users. And you can see the numbers of events, that is serious hypoglycemia events, we identified in each cohort, the majority of which were identified on emergency department claims that we have access to. You can see the person years contributed by individuals in those groups, and you can see here the crude incidence rates of serious hypoglycemia, again, in concomitant users of glyburide and statins or fibrates. Again, not looking yet into the differences between different statins or fibrates. Most notably, you can see that glyburide and glimepiride had higher crude incidence rates of the outcome than the glipizide. So here are our findings, and I'm going to spend a few minutes on this slide because it's a little dense. There's a lot of information here in a small space, but this is really the crux of our finding with respect to a drug-drug interaction. Now, these are our propensity score adjusted hazard ratios. That is, these are results that are adjusted for potential confounders, looking at our outcome of serious hypoglycemia within 180 days of individuals starting concomitant therapy. We had individual cohorts of users of glyburide, glipizide, and glimepiride, or sulfonylureas. We also looked at findings in users of metformin with either a statin or fibrate, in which you would expect no pharmacokinetic interaction because metformin doesn't use the liver for metabolism. But we use these findings to help contextualize what we found for our sulfonylureas. You can see each of these individual symbols is a different statin or fibrate drug that was concomitantly that was concomitantly prescribed with the given sulfonylurea. And what you'll note is that pravastatin served as our referent. So for instance, these are concomitant users of glyburide with atorvastatin compared to concomitant users of glyburide with pravastatin. So each one of these shapes is compared to pravastatin users. The other thing you'll notice is that the shapes that are colored in red are drugs, that is, the statin or fibrate drug. Does that drug inhibit the metabolic pathway that is used by that sulfonylurea? So if we were seeing a pharmacokinetic drug-drug interaction, you would expect that all of these red-colored statins or fibrates would be increased above 1 and statistically significant. That is elevated risk of serious hypoglycemia because they're inhibiting the metabolic pathway, and the concentration of the sulfonylurea drug would be increased. But you'll notice immediately that there's no consistency here with respect to the fact that all of the red-colored statins or fibrates are above the null value, which is the line at 1. But what you'll see very interestingly is that regardless of whether or not the fibrate drug inhibits the metabolic pathway of the given sulfonylurea, that there appear to be, in most cases, statistically significantly elevated hazards of serious hypoglycemia in concomitant users of fenofibrate and gemfibrozil with the given sulfonylurea. So in glyburide users, fenofibrate concomitantly prescribed increases your risk about 30%, gemfibrozil about 50%, and you can see this consistently across sulfonylurea drug. And while we didn't have a lot of power in our metformin group, as evidenced by our wide confidence intervals, you can even see the suggestion that in concomitant users of metformin and fenofibrate, in which there should be no pharmacokinetic interaction, a similar, in terms of numeric point estimate of a 60% increased risk. So you might be thinking, what's going on here? I'll get to that in a second. The other thing we did is we looked at the time course of the drug-drug interaction. And I'm just giving one example here of these individual sulfonylureas in which fenofibrate was added. And we looked at the time since concomitant use. That is in the first month of concomitant use, second month, third and fourth months, and then fifth and sixth months. And you can see that depending on the sulfonylurea, you see different patterns of when the serious hypoglycemia risk is the highest. So in glyburide, for instance, you can see that the risk doesn't seem to occur in the first month of concomitant use, but the risk almost doubles in the second month. And then as you go on months 3 and 4 and 5 and 6, heads back toward the null value. Whereas in glimepiride users with fenofibrate, you can see that the risk starts out at around 30% increase and then peaks in the third and fourth months as a 2.5-fold increase in serious hypoglycemia. Again, somewhat of a delayed drug-drug interaction. So what's the putative mechanism here? Well, one might expect that if there was a pharmacokinetic mechanism going on here, as I pointed out earlier, all of the statin and fibrate drugs that were colored in red that have been demonstrated to inhibit the metabolic pathway used by that sulfonylurea, we would expect to see all those, and only those, increased above the null value, which was a hazard ratio of 1. We didn't see that at all. Plus, we would expect to potentially see a pharmacokinetic mechanism manifest early after concomitant therapy. So these delayed effects pushed out to the second month of therapy and the third and fourth month of therapy aren't consistent with a pharmacokinetic mechanism. That being said, a pharmacodynamic mechanism might be expected to manifest later. So is what we're seeing here really not a drug-drug interaction per se in terms of pharmacokinetics, but maybe a pleiotropic effect of fibrates? Now, as folks on the call probably are aware, fibrate drugs act at the PPAR alpha. PPAR alpha is very prominent in the liver. It leads to increased free fatty acid oxidation and decreased triglycerides, which leads to decreased circulating triglycerides. It's essentially the reason these drugs were prescribed to the patient to begin with. They had high triglycerides. These fibrate drugs act at PPAR alpha, and it decreases circulating triglycerides. But there's a complex relationship between fatty acids and glucose, such that these changes in fatty acids could actually lower blood glucose. So that's PPAR alpha. But there's also some suggestion that these fibrate drugs, which are used for the high triglycerides, might also act at PPAR gamma. And as we know, the gamma subunit is also the site of action for thiazolidinediones, a drug used in type 2 diabetes to lower blood glucose. Now, it's been demonstrated that at least one fibrate, not a fibrate available in the US, but bezafibrate, may have activity at both the alpha, its intended effect, and gamma subunits, and therefore possess anti-diabetic properties. This is work done by our colleague James Flory at Cornell University. So might we be seeing this with our fibrates under study? That is, the complex relationship between free fatty acids, lowering glucose, and some potential activity of these drugs on the PPAR gamma receptor to lower blood glucose. So the bottom line is this: there's likely a drug-drug interaction between sulfonylureas and fibrate drugs. It's probably mediated by pharmacodynamic, that is, not cytochrome P450 liver mechanisms, as evidenced by its delayed onset. It may take some time for this PPAR alpha pleiotropism to take effect. It's unclear how long it would take this PPAR gamma activity, that is the site where TZDs act, to occur. But it's really challenging to determine the relative contribution of these mechanisms. And we didn't set out to identify the mechanism. We're really speculating on mechanism here. But what became very clear to us is, regardless of mechanism, in individuals taking one of those three sulfonylurea drugs, and fenofibrate or gemfibrozil, that it can cause serious hypoglycemia either early and or late. So our advice for prescribers would be that when initiating concomitant therapy or adding a drug to ongoing therapy, that they should remain vigilant to loss of glucose control early on in concomitant use and later on in concomitant use. So back to our talk roadmap. I've told you already that sulfonylureas are still relevant, and in fact, they're the #1 add-on to metformin in dual therapy for type 2 diabetes, and their use isn't going away despite newer agents coming to the market. I told you that glyburide, one sulfonylurea, versus glipizide, another, may carry a 50% greater risk of serious hypoglycemia. And then I've told you that the combination use of a sulfonylurea plus a fibrate drug, when compared to concomitant users of sulfonylurea and pravastatin, may increase one's serious hypoglycemia risk by 30 to 60%. I'd like to acknowledge a number of folks that worked very hard with me in this research that I presented here: Sean Hennessy, Warren Bilker, Mei Zhao, Serena Cardillo, Colleen Brenzinger, Young-Hee Nam, and Eileen Hahn at Penn. The late Dave Flockhart at Indiana University, James Flory at Weill Cornell, Josh Gagne at Harvard, and Patrick Archdeacon and Christian Homp at the Food and Drug Administration. I do want to point out that what I presented today, that is the interaction between sulfonylureas and statins and fibrate drugs, is just one example of a number of pharmacoepidemiologic studies of clinically important outcomes that we've conducted on drug-drug interactions. So all of these studies in the completed section are published work. So we've looked at sulfonylureas and anti-infectives on hypoglycemia, warfarin, antidepressants and bleeding, statins and a host of outcomes, metformin and PPI's effect on hemoglobin A1C. We looked at the very controversial interaction of clopidogrel and PPIs on the risk of ischemic stroke. We looked at hypoglycemia from antihyperlipidemic drugs with TZDs, another drug class in type 2 diabetes. We looked at GI bleeding and intracranial hemorrhage in users of warfarin with antihyperlipidemics, and then proton pump inhibitors with NSAIDs and the risk of different kidney injuries. And we have ongoing work, so more of these types of studies will be coming. For those interested in learning more about this type of pharmacoepidemiology and what we do here at Penn, we do have training opportunities that range from a very simple clinical research certificate that's really intended for local folks here at Penn already, but then more advanced training in a master's degree program in clinical epidemiology, as well as a PhD in epidemiology. And to point out for those interested in getting additional training in these areas, we do have tuition and stipend support potentially available for those interested. So I will stop there and see if individuals have any questions. So let's see. So Right, so someone asked, how did, I'm presuming that this is with regard to the drug-drug interaction component of what I talked about. Essentially, how did this compare to single drug baseline and precipitant entry? So I think if you're asking for this particular interaction, did we examine differential effects of serious hypoglycemia in people that entered the cohort in different ways, that is, were precipitant triggered versus combo triggered versus object triggered? And the answer is yes, we did investigate that. And we saw no differences in this particular study in people entering the cohort in different ways. And my guess is that's because this wasn't mediated by a pharmacokinetic interaction. So it really came down to the fact of when the individual was started on the fibrate was likely the riskiest period of having the serious hypoglycemia. That being said, in other examples that I haven't presented here, we've seen some small differences in these different groups. All right, I'll wait a few more minutes just to see if any other questions come through. All right, well, not seeing any others come through right at the moment. I do want to thank folks for participating in this session today, especially folks that were able to make all three sessions focused on the health effects of drugs and studying drug-drug interactions. And we appreciate your feedback. So I know we typically send out a little questionnaire that goes out after each session. So to the extent that you have comments, it'd be great to hear from you so we can improve webinars and sessions like this in the future. Let's see. Another question came through. Right, what criteria should a person use to decide if they can use high-dimensional propensity scores? Right, so that's a great question. So high-dimensional propensity scores are an empiric approach to identify potential confounders that was developed by Alan Brookhart and Sebastian Schneeweiss at Harvard University. I think in their seminal paper that was published in either 2008 or 2009 in Epidemiology, they would argue that any database that you can identify that is pharmacoepidemiologic database that you might use, to the extent you can identify domains, and I'll tell you what I mean by domains in a second, you can consider employing high-dimensional propensity scores. And how you normally think about domains for identifying confounders are settings in which the individual has healthcare claims that you might be concerned would provide information on confounding factors. So in our studies, we normally identify 6 or 7 domains, those being inpatient hospitalizations, ambulatory care visits, long-term care facility visits, prescription drugs. All of those types of things are domains. You could think of laboratory orders. To the extent your database has it, you can think of laboratory results. So probably beyond the scope of what I can answer in this question here is, generally you can always consider it, although there are some pretty good guidances written by the Harvard group that help you walk through thinking about whether or not high-dimensional propensity scores would be relevant for your particular study. I know there's some issue with rare exposures, small sample sizes, things like that. All right. Well, seeing no more questions, again, I want to thank everybody and take care.